Good afternoon. My name is Carolyn Cass, and I'd like to welcome you tonight and thank you all for joining us for this session. This presentation will be the first of a two-part series with KidGen and will focus on PKD and your health, staying healthy with PKD. Tonight, we will hear from our esteemed speakers, Professor Andrew Mallett and Dr. Peter Trnka, who will lead our presentation with a focus on the current best practice clinical management of PKD for adults and children in Australia. Professor Mallett is an adult nephrologist with a special interest in genetic kidney disease and nephron genetics. He is a current Queensland Health Advancing Clinical Research Fellow with a strongly emerging clinical and research profile in this field. Currently Professor of Medicine and a Clinical Fellow, Professor Mallett is also National Director of the KidGen Collaborative and Director of Clinical Research and Nephrologist at Townsville University Hospital. Dr. Peter Trnka is currently the Service Group Director of Endocrinology and Nephrology at Queensland Children's Hospital. He's the Director of Queensland Child and Adolescent Renal Service, a statewide service providing nephrology care for children with kidney disease, including dialysis and kidney transplants. Peter holds a Master of Science degree in Experimental Medicine from the University of British Columbia in Canada, and he is also Associate Professor at the School of Medicine at the University of Queensland. And I will hand over to Andrew and Peter in a moment, and following their presentation, we will then move on to the Q&A portion of this evening. So we have received some questions in advance that Peter and Andrew will be going through, and that will be covered during the presentation in their content. But if there's any other questions that crop up during the evening, please feel free to use your Q&A icon button at the bottom of your screen, and feel free to type in your questions, which we will then endeavour to go through at the end. And now, please welcome Dr. Professor Andrew Mallett.
Wonderful. Thank you so much, Carolyn. And thank you to PKD Australia for the invitation. It's amazing to be doing this event, this seminar with you all, and most especially with my good friend and colleague, Associate Professor Peter Trnka, who has, we worked together for many years, or should I say he has tolerated me for many years. And so this is really quite natural for us. Today, the brief outline is we'll be talking about, we'd like to talk about, PKD care in adulthood, and then obviously Peter will follow on talking more specifically about it within childhood and adolescence. And then because we've had an amazing response from so many of you, we've got a great series of questions that have been submitted that we'd love to walk through in a really discussional way, which we hope that you'll really enjoy. And also we hope to generate more questions together with you. So in the PKD care and adulthood section, I thought I'd start out. My aim really is to keep it simple, but keep it amazing. So I think that particularly in this kind of setting, keeping things as clear as possible is actually really key, because the most important thing I tell my patients with ADPKD is that they are well and healthy people who just happen to have PKD, and that's the basis from which I'm coming at this from. So the key areas I'll briefly walk through, and deliberately I'm going to be brief because we want to keep plenty of time for questions at the end. And by plenty of time, I mean more than half of the hour. Talk about diagnosis and the different ways that happens. Longitudinal care, which is actually really important. I think that's important to talk through in terms of those future care horizons. Potential complications, which are always, can be surprises that happen. And I think it's important to demystify that. Management in a broad sense of the condition, but then also specifically treatment. And I make a differentiation between management and treatment because I think they are subtly, conceptually, a little different. So first of all, in terms of diagnosis, whilst we have a fairly clear framework at this time as to what constitutes formulating a diagnosis, I do think of it in this kind of a frame. I would note at this time as well, whilst this maybe is being recorded and may be accessed in the future, right at the moment, the KDIGO ADPKD guidelines draft is open for consultation, and would welcome and encourage all of you to go and have a look. The other reason for not putting a lot of granular information here in my slides, particularly in the adult space, is because those guidelines may modify some of the things I'm talking about just a little bit, and no one wants to become uncontemporary, let's say. So the ways that I see patients coming to diagnosis is sometimes incidental. So this is someone develops abdominal pain for reasons other than, ADPKD, and there's the incidental finding of kidney cysts. There are those people who are at risk of the condition by virtue of having a sibling, parent, or other family member who's affected, and specifically I'm talking about ADPKD here, and choose to have a predictive imaging test done. And then there are those who present with symptoms. So this may be a person who presents with hypertension or a complication of ADPKD, such as hematuria or kidney stones or something else like that. And so they're a symptomatic individual, and that leads to them having a diagnostic imaging study, which arrives at the diagnosis. And the approach for us in each of these is a little different. Coming from an imaging perspective, the good news is that the evidence-based guidelines in terms of the number of cysts that need to be seen is quite clear. There are Australasian guidelines, the CARI guidelines, that tell us as clinicians what that needs to be by age and by modality. And it spans both childhood and adulthood. So this is a really nice space. The important thing I would emphasize here is that when we're talking as, treating clinicians, and this may be your general practitioners as well as your treating kidney doctors, we work in a quantitative world. And so qualitative statements like there were many kidney cysts may not be particularly meaningful for us, because many means different things to different people. So I often actually ask, what is the absolute number of kidney cysts? What's the absolute kidney length? And you'd be surprised. Actually, we sometimes need to be pretty blunt with that level of questioning. Next is, what's the method? And as I've mentioned just here, a lot of the times this is with imaging, and this can be ultrasound or cross-sectional imaging, such as particularly things like CT, or occasionally, just occasionally, things like MRI. Most commonly it's ultrasound, because that's something that is easily attainable in many settings. But the key bit I often find that's really important here, and I hear from many people, is the counselling component. So this isn't a tick and flick exercise. It's important that there is that counselling component that goes around. So for the patient or person with an incidental diagnosis, actually on the fly counselling is really important, because this may be a diagnosis that's coming as an immense shock to them, particularly if they're what we would call a de novo case, so a first in family case, where there's no touchstone of what to expect. For the at-risk individual who's had a consciously undertaken predictive test, again, further counselling around that decision. And though also for the symptomatic individual, different types of counselling. I think that is just so important from us as kidney doctors to provide, to help people through this journey as they're actually having the diagnosis formulated. So the next part that I think is really important, and our colleagues in the United Kingdom, Albert Ong and Sheffield, talk about these three key phases conceptually of PKD care that they've hypothesized that there's a diagnostic component, and then the next part is a care component, a prognostication or care component, and then the last part is a treatment component. So the second part for me is this, around longitudinal care. And for me, I put the big red star here. This is mission critical. This is absolutely key, because if we get this wrong, the potential for inadvertent non-benefit is really high. This involves obviously primary care, so general practitioners. It clearly also involves kidney physicians, I think, both pediatric and adult. And, for those younger people and children being diagnosed, as Peter will talk about, transitioning into adult land is a really key step. And having a friendly adult renal physician who has these relationships is key for those younger people. And then also other contexts. So this can be other clinicians at different specific time points, such as, say, a clinical geneticist and genetic counsellor, during times of diagnostic uncertainty or beginning, discussions around family planning. And that can also include obstetricians, gynecologists, IVF specialists, all those different things for those individual times, urologists, kidney transplant physicians, for whichever specific part of that longitudinal journey. But the key part here, I think, is the primary care physicians, and particularly the renal physicians. The other reason for emphasizing this is that in my practice, even for those patients, of which some of you may be, who are affected by PKD with preserved kidney function, so CKD stage 1, we know that if at some point there's progression to CKD stage 2, and thus other things become an option, such as specific treatments or complication surveillance, those can generally only be provided in an insightful or thoughtful way by actually the kidney physician. And so if one is disconnected from that care, even if that's just a once-a-year appointment, as I have many patients, that's exactly what we provide, then that benefit can't be taken up. So being connected to care, even if that's just that one appointment once a year, I think is really very important. The frequency and screening part is part of that. So that how often we see people, for the care, depending on our complication profile and things, that'll vary through the lifespan. But it needs to turn up as the heat goes up and needs to go down as the temperature goes down. And I think that that's a really important discussion to continue to have. And, as I said at the beginning, given that this is a condition where the general paradigm is that one is a healthy person who just happens to have this, in fact, the frequency of appointments in most instances shouldn't be getting in the way of living life and doing normal things that a patient or family would like to be doing. The active screening component, as I'll talk about in a second, for complications is a really key thing to be talking about here, and changes over time. Our evidence base for different types of screening for different potential complications varies. So we're only just really getting to a time point where there's good consensus, for instance, about who to screen for intracerebral aneurysms. But the next question of, well, what next? How often do we rescreen and when do we rescreen? The evidence base is not as good. And so continuing this discussion, I think, is actually incredibly important. Genetic testing in this space, given that the vast majority of patients we see are diagnosed on imaging criteria, is a really important secondary part that can be involved, that can occur for different reasons at different times: transplant planning, family planning, prognostication. And as Dr. Chirag Patel, who's presenting in a couple of months, will be talking about, that's a really important thing to get engaged with at that time, if and as the indication arises. Now, potential complications. Broad brushstrokes here is the deliberate approach I'm taking. So first of all, blood pressure screening. So given that early hypertension may be actually pretty asymptomatic, the only way to know that you have it is to measure it. What isn't measured doesn't exist. So, but that doesn't mean you don't have it. So measuring blood pressure to identify early stage hypertension and be appropriately treated is really critical. For many patients, it may be actually the very first sign of the condition or complication of the condition that occurs even in the presence of normal kidney function. Cerebral aneurysms, as I just mentioned, knowing who to screen, and at the present time, that's generally those who have a first-degree family member who's been affected or who has a history compatible with being potentially affected. This is an evolving space. The proposed KDIGO guidelines may slightly change this in the near future. Liver disease, as comes up in the questions at the very end, really important thing. So this can affect anywhere up to approximately 3 to 5% of people affected by ADPKD. Obviously, for those with ARPKD, it is a much higher proportion of cases. And in fact, I've seen some people where they've got a liver predominant presentation of ARPKD, and the kidney part is only diagnosed down the track or in early adulthood. But for those with ADPKD complicated by liver disease, there is a bit of a changing paradigm. We know there is a female predisposition here, not because of a gender predilection of the condition, but rather because genetically it's at least, but rather because of secondary hormonal influences around the evolution and development of that liver disease. And importantly as well, there may be different management strategies that are required. I've cared for a number of patients in the past who've had substantial negative impacts on their quality of life due to very substantial polycystic liver disease complicating their PKD. And it's important we involve our multidisciplinary team in the management of that. And I've seen that done really successfully in a number of instances. Not easy necessarily, but important. Cardiovascular disease is key here, linking into blood pressure. Many patients, are at increased risk, particularly as kidney disease, their CKD may evolve over time. And so thinking around primary management of that, lipid lowering therapies and the like is key. For some subtypes of PKD, things like considering things like diabetes. So there is a subtype of ADPKD, which sometimes is thought of as what we call a phenocopy disorder. So if you consider that PKD is the horse, we're talking about a zebra here. It's kind of same, but different. And we call that renal cyst and diabetes syndrome. And this is a special syndrome where, because of the type of the genetic underlying cause, a patient may develop an inherited form of diabetes, either primarily or secondarily in association with that PKD. Last but not least is progressive chronic kidney disease. Now, this is the bit that we talk about a lot. You come to see a kidney physician to talk about kidney disease. So this is what that is. Prognostication here is so very key and important for many patients, and us trying to work out how we do that through whether that's kidney volume, which is less done in Australia but very valid, kidney length, pro-PKD score, which is a genetic kind of prognostication, or other mechanisms, is really important so that people have a general expectation of what's coming into the future. Moving on to talking about PKD management and adulthood. And as I said, I'll talk about treatment, which is targeted treatment, in just a second, but hypertension management, there's very evidence-based guidelines now as to which are the lead treatments that we want to use for blood pressure, and which has got the most evidence for most benefit. Importantly here, there has been some thought in the past that some medications, like our calcium channel blocking blood pressure medicines, do they have a negative impact? The trials and evidence we have to date have not borne out any evidence that that's the case. And so those evidence-based guidelines are really clear, and your treating kidney doctors and general practitioners are well across them. Diet and lifestyle is arguably the thing that we could have a whole afternoon seminar about. There's lots of emerging evidence about different approaches, potentials, but the key thing here that I recommend to all patients, particularly with early stage CKD, secondary to PKD, is a full and healthy diet. If modifications required, we would always engage a specialist dietitian to advise. There are things such as are being proposed at the moment, like ketogenic diets and things that many of you may have heard about. The evidence for that is only emerging. It isn't necessarily something that's well established in practice at the moment, but more research is required, as I'll talk about in a second, to define whether there is a role, and if there is a role, what does that look like? So we're not closed to this, but in the absence of specific evidence of benefit, we don't find ourselves in a position of saying everyone should be doing this. Hydration is important, and as you can see from my backdrop, I happen to be in tropical North Queensland, and it's summer, so hydration is critical. What I tell my patients is there is no evidence at this time to suggest that forced increased oral intake, to superhuman levels of volume intake, so water consumption, has specific benefit in this condition. However, that doesn't mean that one should be actively avoiding becoming dehydrated. So what I tell my patients is to ensure that you're adequately hydrated for the circumstance you're in, and avoid dehydration at all costs. So if you're working outdoors and it's summertime, you may need to drink, a lot of water, 5+ liters, because of perspiration and other insensible losses. If you're an indoor worker and it's a colder climate, that might be a smaller amount, so closer to 2 liters. But discussing that with your GP and your renal physician is so important to, I think, to modify. As I said, screening for other complications, as we've just touched on, and also other things that come along, such as discussing things like family planning and the like. Your kidney doctors are really able to help, I think, in not giving some answers, but even if they don't have all the answers, directing to who is the best port of call to give that advice. Treatment, unfortunately, remains too small a slide for PKD. So in the top left here, I have tolvaptan, which is a subsidized treatment for adults with PKD, and has the best evidence at this time. That is evolving, as Peter may be talking about. Things may change in other spaces in the coming years, but certainly for adult patients, this is indicated and reimbursed in Australia for certain patients. Clinical trials are absolutely key, I think, to the future of PKD care, and I would strongly be advocating to to patients and families to be considering these as they become available. My conflict of interest is I'm involved in a couple of these trials, so please, I don't say this out of pure self-interest. I say it because I'd like to be able to offer more things to more patients through the remaining decades of my career. Kidney replacement therapy, which is things like dialysis and transplant, is something we need to talk about from time to time. but we're getting better clarity in terms of that prognostication as to when that might be likely for patients. And there's good emerging evidence too, and actually really quite clear evidence, that patients with PKD do very well if and when required, and we don't want anyone to be on dialysis earlier than they need to be, but that they benefit from this if it becomes indicated. And in fact, often are really excellent kidney transplant candidates, largely driven by the fact that the patients with PKD, often this might be the only major medical issue that they're confronting. Other patients with other causes of advanced kidney disease, there might be other issues also, like active cardiovascular disease, diabetes, and the like. The future, because of all these things, looks very bright. There are key things on the horizon that I won't go into too much detail because I won't do them enough credit, like bioimplantable kidneys, kidney scaffolds, all kinds of things. These are things that are hopefully coming within my career's lifetime. They aren't here today. It's important to keep across them because I think that's really important to generate hope for us and our children and grandchildren into the future. For me, the key take home is, what do? I individualize the care for the person who's with me. So I care for some people who live in rural communities here in northern Queensland. It looks a little different. I look for some people who are older and approaching needing to discuss things like dialysis. And again, that looks a little different. I also see a lot of people in our statewide kidney genetics service who are asking the big questions around, well, when am I likely to need things like dialysis? What can I do to change the risk of my offspring being affected by this condition and the like? I individualize the knowledge that I have in those contexts to help the people for the questions that actually matter for them. And I know that many of my colleagues, if not all my colleagues in kidney medicine, often are very similar. And if I don't know, I find someone who does. And I'm really fortunate to have lots of great friends around the place, like my colleague who's talking next, Dr. Peter Trnka. So I will hold over to questions at the end, but I will now hand over to Peter and I'll keep flipping through the slides. Over to you, Peter.
Good evening, everyone. Thank you, PKD Australia, for inviting me. It's exciting to talk tonight to all of you, and I hope you are keeping yourself cold and well hydrated, because it was very cold here in Brisbane. Sorry, cold, hot, 35 degrees. So I'm a paediatric nephrologist from Brisbane, Queensland Children's Hospital, and we provide the care for the whole Queensland. So next slide, Andrew, please. I was going to, this slide shows you where we actually have the services provided for paediatric nephrology in Australia, and also including New Zealand. So we started, I borrowed the map from KidGen, and we started KidGen in Queensland, as you can see, Queensland Children's Hospital. So we cover the whole Queensland as a statewide service. Then as we go around the border of Australia, you see in New South Wales, there are two paediatric hospitals, Sydney Children's and Westmead Children's Hospital. Next in Victoria, you have Royal Children's and Monash Children's Hospital. In South Australia, Women's and Children's. And then on the West Coast, Perth Children's Hospital. The North is not that well covered. And in fact, the people or kids with kidney disease from Darwin come to Adelaide or sometimes to us as well. In New Zealand, there is one paediatric nephrology service in Starship Hospital in Auckland, and they cover the whole country. They have a very good system there. Next slide, please. So very briefly, I just touched on genetics and pathogenesis, and you will have the talk by Chirag, who is an expert on that, so I didn't want to go deeply into it. But basically, there are two main variants in autosomal dominant polycystic kidney disease, PKD1, and two variants. They're on chromosome 16 and 4, respectively. And as you can see, they cover about 92 or just over 90% of all the variants that we find on genetic testing. There are some other genes emerging as well. But what is important to remember as well, if you do genetic testing, and I hope that this is correct, probably 7 to 10%, according to the literature, might be de novo variants. So they are not inherited. They are just first developing in the person affected. PKD variants, they code for the proteins called polycystins, and they are really important. And they are in the primary cilium of the cell, which is involved in the signaling of the cell and communicating of these cells with other cells. So if that doesn't work well, basically the cells get a little bit crazy and you develop cysts. And there are cystic dilatations in all parts of the nephron compared to the autosomal recessive polycystic kidney disease that involves only the distal part of the nephron, or the last part. Next slide, please. So what happens then if you have abnormal function in those genes? You develop cysts, and you know this well, kidney cysts, large kidneys, and also cysts in other organs like liver and pancreas. In children, we don't see that very often, but occasionally we find maybe one cyst in the liver. And also Andrew mentioned already cerebral vessel malformations, and these are extremely rare in children. Next slide, please. Now I move to how we actually diagnose these children in our clinics into that pediatric area. So one of the most common referrals is there is an abdominal imaging done for screening in the family that already know someone is affected for ADPKD. There can be also incidental finding of cysts on the imaging. Usually it's renal ultrasound or kidney ultrasound for unrelated conditions. A child develops tummy pain, or they have a urinary tract infection, and someone does the ultrasound and they discover the cysts. We had a few years ago, there is an early onset of ADPKD. We had about 5 or 6 patients that were diagnosed actually antenatally or very early in life. We call them early onset or very early onset of ADPKD, and we published a series of these. So you can find out on antenatal or very early ultrasound in childhood. In fact, when I was starting my pediatric nephrology training, ADPKD was called adult polycystic kidney disease, and ARPKD was infantile. So you can see that that's not true. And also, as Andrew mentioned, you can find the cysts while investigating some other problems such as hypertension or proteinuria. Next slide. Clinical manifestations in children with ADPKD. I can tell you majority of kids are asymptomatic and healthy and well, and they are growing well. And we just do the screening, follow-up in the clinic and monitor them. What we look at is hypertension, because that can be the first sign. And I have a few patients who have high blood pressure. If the last part of that nephron or filter is affected, that's the part where you concentrate urine. So some children might be polyuric, so they need to drink a lot of water. You can develop proteinuria. Occasionally we see the urinary tract infections. We don't see a lot of, in pediatrics, a lot of cyst infections, but I have seen that in adults, certainly. I have a couple of patients who have abdominal or flank pain. And I saw one boy yesterday, and he has large cysts, and it might be related to a flank to his large cyst. And hematuria is another sign, so blood in the urine. In kids and adolescents, in most of them, in fact, I would say probably in all of them that I have, the kidney function or GFR remains completely normal. Next slide, thank you. So screening for autosomal dominant polycystic kidney disease, if you have positive family history, there are a couple of questions about that. What we do in our clinics, we don't advocate to screen children if you have parents or siblings, older siblings affected by ADPKD. The reasons for that are few. One, there is no treatment at the moment for children that can help very early. Second thing is, if you don't know, you just don't worry about that. So you don't have this pre-existing condition that can have an emotional, employment, insurance impact on you. And the other thing is that if usually screening is done by the ultrasound, kidney ultrasound, and it's not very sensitive in young people. So in other words, you can have no normal scan, but it does not exclude the autosomal dominant polycystic kidney disease. So as I mentioned, what we do is we regularly monitor these children who are at risk, and adolescents. We see them in the clinic, measure the blood pressure, and we do the urinalysis. We don't do a lot of blood tests compared to the adults. We would consider referral to genetics when the adolescents reach adult age, because it's really important for them to basically learn about the disease and decide what they want to do in the future. Ultrasound is the most appropriate screening tool for the cysts, basically. And as I mentioned, the negative result does not exclude ADPKD. In children, and I hope it's still true, Andrew, one cyst can be, if you find one cyst, it's very suspicious in at-risk person that this is autosomal dominant polycystic kidney disease. Genetic testing is costly and most of the time is not done. We can do it in some cases that are complicated or we don't know what the cause of the cystic disease is. Next slide, please. When I was looking at what other people do, some people say that you can offer, and that's true, you can offer screening for ADPKD to children if it's desired by the parents or the guardians, but it's always good to do first the counseling about the potential harms and benefits of the screening, but also how sensitive the tests are and how you are going to screen. And I would say whenever possible, it's good to involve adolescents and mature kids in the decision-making process because it's about them, it's about their disease and health, basically. Next slide. How do we manage in pediatrics? And we all do things differently, but this is what I do. Children with ADPKD, usually it's annual review in our clinic. If there is someone who is the new patient, a new diagnosis, we generally have discussion about ADPKD, about genetics briefly, about clinical manifestations that I told you, and about progression or lack of progression of the chronic kidney disease in childhood. We usually take personal and family history. We examine the child, including the growth, which is really important in childhood. As I said, blood pressure, examine the skin, always because there might be some other disease, and I'll mention that at the end. Investigations-wise, we do renal ultrasound or kidney ultrasound. Sometimes I do abdominal ultrasound, and Andrew mentioned that there is a KDIGO review of the guideline, and one of the questions was whether people should be doing abdominal ultrasound in childhood because the cysts in other organs are rare. But I do occasionally abdominal ultrasound, usually in adolescents. We don't do a lot of blood tests because if you do it, generally it's normal, and we do the urine tests just to look for blood and protein in the urine. We also make sure that other affected family members have appropriate follow-up with adult services. Next slide. So the complications that we see in children, blood pressure. I have a few patients who have high blood pressure. We can monitor this in the office. I always ask people whether they have the blood pressure monitor at home because that's good. A lot of families do. So there are probably better readings than one-off in the clinic. And the gold standard that we use, if we are not sure if this is real hypertension, we can do 24-hour blood pressure monitoring through our service as well. Treatment-wise, we use mainly AC inhibitors or angiotensin receptor blockers. That first group is the prils, so captopril, ramipril, enalapril, lisinopril. The other ones are sartans, candesartan, irbesartan, and so on. The target in children, in adults, it's easier because you have one target. In majority of adults, in children, it depends. Your blood pressure depends on how big you are and how old you are, and on your sex as well, whether you are a boy or a girl. So the guidelines say we should target 50th percentile of the blood pressure for your age, sex, and height. I find it a little bit difficult because a lot of people have actually normal blood pressure, and if you treat them, then if you get to 50th percentile, they can be a little bit dizzy. So as long as we get below the 90th percentile, I'm happy. The other thing is proteinuria. We mentioned you can do monitoring a dipstick. We can do random urine samples. We usually do them in the morning because that's the best time for protein or albumin to creatinine ratio. And we don't do very often timed collections or 24-hour collection because it's really difficult in kids sometimes. The treatment is the same as blood pressure with AC inhibitors or ARBs. Next slide, please. Dietary and fluid management, we usually recommend normal diet. The only thing that if the blood pressure is high, we would say you kind of don't use too much salt. And how I say that to the families is you can cook with salt, but don't add more salt after you finish cooking. And also we talked about chips and pickles and things like that contain a lot of salt. And we can get involved our dietitian with helping as well. We recommend normal fluid intake because most of the kids are either polyuric or have normal urine output, trying to avoid dehydration. We don't restrict protein because we want to achieve normal growth of these people, of children. And as I said, now a normal balanced diet is really good, and it's important to avoid obesity or being overweight. Next slide, please. Other management, if the kids have pain, we encourage them to use paracetamol first, but they can use ibuprofen. I usually say, because sometimes people say, I can't use it. You can use Nurofen as long as you use it wisely. So in other words, if you are dehydrated, you have gastro, you have tummy pain, and using Nurofen every 4 hours, that's not a good idea because the kidneys can kind of shut down the blood flow. But if you use a few doses over a certain period of time, 1 day or something like that, that's fine. Urinary tract infections, that's not different to any other children that we how we diagnose and treat. So usually we encourage people go to, if they have symptoms, to the GP, get a sample, start emptying antibiotics and adjust the treatment based on the culture. Trauma, we don't see very much of that in kids because they don't have huge kidneys. The questions always asked by the parents are asked whether the kids can participate in sports, contact sports. I usually encourage people or children and adolescents to do sports because it's good for you. And the amount of kidney injuries or ruptured cysts that we see is close to zero, really. So I encourage them. Tolvaptan, Andrew mentioned, we haven't used that in children. And it's not because it can't be used, but one of the criteria for using it is declining kidney function. And whenever we check the blood test, the kidney function is normal. So we just need the pediatric studies, whether we need different markers of the progression and things like that. The future will tell us. Next slide, please. And just very briefly, my last slide is, it's not only ADPKD, there are other cystic kidney diseases. So ARPKD, a recessive type, we see a few patients, and that's more severe. They can get other organ involvement, especially the liver, and they might need double organ transplant. In fact, I don't have that patient anymore. I transferred to Andrew, but a young lady who we looked after on dialysis for many years, and then she received a kidney liver transplant. She has done really well. You would never know that she had a two organ transplant. Andrew mentioned renal cysts and diabetes syndrome. The gene is HNF1 beta. It's on chromosome 17. And sometimes, historically, we didn't do much because we didn't know about this gene, but we now know that a lot of children have that because we do the chromosomal microarray, and that's a good starting test in our clinics if we think that the kidneys are smaller, they have a lot of cysts, and they might be also a family history of diabetes, for example, as Andrew mentioned. Tuberous sclerosis complex is a genetic condition that I see a lot of patients with as well, and about half of people with TSC will have kidney cysts as well. And there is one group of this, it's about probably 3% of patients with TSC, they have something called contiguous deletion syndrome. So on chromosome 16, PKD1 gene is next to TSC2 gene, and you can get this large deletion or damage basically to that chromosome, and it predisposes you to a lot of development of cysts. And in fact, I have a boy who, when he was 1, he had kidneys full of cysts, and he had adult size of kidneys. So that's very different. It's more severe, and I'm not sure what will happen with patients like that because they have quite significant cystic involvement of the kidneys. And then there are other cystic kidney diseases as well. Usually it's part of various syndromes, and they can, because of different reasons, progress. So we tend to follow up these people in our clinics, and again, we monitor for their kidney function because they can develop chronic kidney disease. And I think that's my last slide. Excellent. So,
and now we get the fun to begin. So we can walk through some questions. Now the questions that were emailed in ahead of time, we've broken up into some broader areas. So the first is, you're talking about diagnostic, kind of frames, and I can see there's already beginning to be some Q&A come in through the webinar itself, but we'll quickly go through these. I think exploring genetic testing in this space, and I don't know, Peter, what you see, because it's a little bit different across the pediatric and adult spectrums, but I think this is about awareness at the present time that it's available. The key thing here is, from my perspective, is there being the presence of an indication, so a reason to be doing it. Doing it just for the point of it may not provide real value. And Dr. Patel, who's presenting in a couple of months, who's is a very experienced clinical geneticist in this space, he'll be able to give more context. But I think we're all trying very hard to ensure that there's increased education and awareness, particularly amongst kidney physicians and then increasingly amongst GPs. But I don't know what you see, Peter, but I see also patients and families are sometimes also the best advocates as well for themselves, and there is a role for them talking to their GPs. Have you seen things like that happening in your practice?
How I see that is, if you have a typical family history with a few generations involved, there is no need to confirm that because it's really clear what it is. In pediatrics, we do genetic testing for cystic kidney diseases when we don't know what it is. There is a first person, it might be some other organs involved as well. So then as part of genetic testing for cystic kidney disease, we would do that. But again, we have very good, and you are part of it, renal genetics clinic, when we every couple of months sit down like this on a virtual platform, and we discuss the cases. So we are really well guided, and I think that's how the genetic testing should be approached. And it's not only about testing, but also about genetic counseling, as you said. So that's what we do basically in pediatrics.
And I think that feeds on so nicely to the next question, which was about, the accessing of genetic testing. And the great piece of news in Australia is that for about 18 months now, there's been an MBS item code specifically that funds diagnostic genetic testing for ADPKD in Australia, amongst other inherited kidney diseases, which is just amazing. And is, whilst there are some criteria, it's not a lot, to be honest, compared to other areas. It's orderable today by renal physicians, both adult and pediatric, as well as clinical geneticists. And so that takes away that thing of, once upon a time, unfortunately, quite a long time ago, either there would be a question of who pays for the testing, whether that's a patient or a health service or what. Now, just like most blood testing that we do for other reasons, there's a funding mechanism from our federal government, which is excellent. How to access that, I think, is asking your kidney doctor about it. There are setups in each state that support kidney doctors in doing it, because obviously this is a pretty new skill set for them sometimes. And we're seeing actually uptake slowly, it is increasing. And there are support mechanisms for kidney doctors to be doing it. Or like you said, also, Peter, referring to virtual or in-person subspecialty clinics, of which we have 19 around the country now, who can take that on and do it, because we do it all day, every day. So this is actually a great space where it's fundamentally changed. 10 years ago, this was not the case whatsoever. There was very minimal, if any, genetic testing happening in this space, or even in kidney disease, full stop, in Australia. But today, it's actually publicly reimbursed, and there are specialty clinics to help.
And part of this whole process, it's the education of the providers, GPs, and the nephrologists as well. Because in the past, we found people, when genetic testing was done at different places, they did not communicate, and even it was done genetic testing for a wrong gene. So I have a patient who someone ordered autosomal recessive polycystic kidney disease gene, and it was not. It was, because it was in a young child, it was autosomal dominant polycystic kidney disease. So you can waste money. So the education of people is really important.
Now, the next sort of pair of questions were actually more kind of diagnostic still, but also really focusing in the pediatric and adolescent space. So, Peter, did you want to walk through these ones?
Sure. So at what age can my children get tested for PKD? So I touched on it. Really, it depends on your family history. If there is if you have cysts, you can do it. You can advocate for it, but we generally say there's no need to test because asymptomatic children at risk. So if your child is well, healthy, my suggestion would be you can take your child to a GP once a year. They can check the blood pressure, and you can do the urine analysis to make sure that there is no protein or blood in the urine. If there's something like that, we will be very happy to see your child in our clinic, and then we can go through it. We can discuss what we can do. As I mentioned, if you do the ultrasound and it's normal, probably not giving you an answer. So then we can have a discussion with our renal genetic clinic about how we proceed about it. But generally, we in childhood don't do the testing early in asymptomatic children. It can be confirmed by the ultrasound, but just remember, if the ultrasound is normal, because I tell people in the clinic, you can be 35 and you can have normal renal ultrasound and it still does not exclude ADPKD. Once you are 40, and I believe that's correct, Andrew, and you have normal ultrasound, then we can say, yeah, you don't have it. So if your child is 15 and has normal ultrasound, that doesn't mean that they don't have ADPKD. Warning signs to look out for ADPKD in children and adolescents. I mentioned some of them. Normally, the kids are fine. They are healthy. They don't have any symptoms. The first presentation usually in childhood, adolescence is high blood pressure. It can be completely asymptomatic. So as Andrew said, if you don't measure, you don't know about that. So that's why we say you go and do the screening, go once a year and do the blood pressure measurement. The other thing is if it's high, we usually don't, it doesn't really mean that straight away that's high blood pressure. We need to repeat it, or we need to use different type of monitoring for blood pressure. Urinary tract infections. So again, if your child has fever, tummy pain, unexplained by upper airway symptoms or something like that, it's good to test the urine. They might have other symptoms such as going more often to the toilet, or the urine is a little bit smelly or something like that. It's good to get that urine tested again. Tummy pains, most of the time what happens is GPs or pediatricians, if the child has abdominal pain or flank pain, they will order the ultrasound. So they might pick it up. But I would probably pick these symptoms. So abdominal pain, maybe urinary tract infections in childhood, and hypertension or high blood pressure would be, it's asymptomatic, because if it's significant, then it's usually, we don't see that in childhood, it's usually in adulthood.
Peter, there's actually an anonymous question that's come in. I was going to put to you in the section, which is a nice segue. So, other than cysts appearing during antenatal scans, are there any other potential indicators in that very, very early age group or in the in uterine period, such as like echogenic kidneys?
That's an excellent question. Yes. The kidneys, whether it's ADPKD or ARPKD, can be just echogenic, which means that they are bright on the imaging and they can be enlarged. And the other thing is, if the kidneys don't work 100% before the baby is born, you can have decreased amniotic fluid volume, because in the second half of pregnancy, the majority of amniotic fluid is made of the baby's urine. But that would be pretty extreme. But we antenatally, before birth, we don't see clearly the cysts. Most of the time, we see enlarged and bright kidneys.
Now, the next lot of questions that have been put to us are of a more general nature, but the first one is about a 17-year-old who's been diagnosed. And is there any general advice you have? Now, Peter, I'd throw to you first, because this is like this critical crossover-y kind of period where we both see people, I think, in this age group. But when older adolescents, young adults are coming to pediatric service or being referred, what general advice do you have?
Well, it's funny, because in our hospital, if you come for the first time and you are 17, they will say you can't come because you have to be, once you are 16, you go to the adult hospital. But the advice for 17-year-old, I think it's important. That's that, as Andrew says, that kind of gray age zone between pediatrics and adolescents. So if the patient comes to our clinic, we would really talk to the family, as I said before, and the person, obviously, about what it is. But I think it would be really important to find appropriate adult services for that person, whether it's in Brisbane or anywhere really across the country. So that would be my advice, really, and then just find and communicate with the adult services.
Yep. And on the adult side, this is a not uncommon at all type of referral. I think, it's a time where I find patients come, and it can be really anxiety provoking. So it's so important we provide, I think, calm, informed advice to be able to guide through what can be a really stressful period. Because, when we're young, we're invincible. But this can be a challenge to that, and it's also really distressing for families too. I find, but that also feeds onto this next question around liver dominant PKD, which is more common, I think, probably encountered in the adult space. I think sometimes does come up very in the pediatric world. But in adult land, as I mentioned earlier, it's about 5%, 3 to 5% of adults affected by ADPKD experience very substantial liver cystic disease, constituting a diagnosis of PLD. Now, the key thing here, we also say to patients is for ADPKD, in fact, it's a supportive thing of the diagnosis if there's a small number of liver cysts, and that doesn't necessarily mean that you have a small number of liver cysts doesn't in and of itself constitute polycystic liver disease. Polycystic liver disease is massive expansion of the kidneys, not of the kidneys, of the liver related to cysts. And unlike the kidneys, actually liver cysts are a real estate issue. So that expansion begins compressing upon other organs, but the liver tissue, even that's interspersed with cysts, remains functional. So the patients I have seen affected by this experience symptoms of compressing, say, their stomach or vessels, or causing lots of discomfort and pain, and even I wouldn't in no way minimize it, but cosmetic issues. So it can give the appearance of, almost appearing to be gravid, so being pregnant, some patients. And this can be really, all of these things can be really distressing and impact quality of life really substantially. And some can be on their own life-threatening. But it's important to walk through it and think about it. But it is absolutely a subtype that we see, and it can be sporadic. And not affect everyone in a family, just 1 or 2 people affected by ADPKD. The next question we had was about EGFR. So this number that we talk about, Peter, I mean, because in pediatric clinics, you have to calculate it. The labs give us this number. How does it work for you guys?
So just very briefly, GFR stands for glomerular filtration rate. And the kidneys do different things, but they mainly clear the blood. So it measures the clearance, how well the kidneys work. And so this concept is you can measure it by nuclear medicine scan, or you can calculate it based on your creatinine in the blood, which is the muscle protein. And people develop these formulas because you don't want to send everyone to a nuclear medicine scan. So there are adult formulas based on, and Andrew knows more about it, based on your creatinine. In pediatrics, we luckily have just one formula. It's called Schwartz formula. And it has the constant, something called K, that we use. And it used to be very complicated in the past, different for small babies, different for boys and girls. Now it's just one. And that K is 36.5, if you want to remember that. And you multiply that by your height in centimeters and divide it by creatinine in micromoles per liter that is measured in our lab. And it will give you the number. And normal number is more than 90. And then you have less than 90, you have basically stages of chronic kidney disease. 1 would be 60 to 90, 2 will be 30 to 60, 3 will be 15. No, I'm confused now. No, sorry, 1 is more than 90, so normal kidney function. 2 is 60 to 90, 30 to 60 is 3, 15 to 30 is 4, and anything below 15 is kidney failure, basically, that you need a replacement of kidney function by dialysis or kidney transplant. So that's how it works in pediatrics.
For us in the adult space, we're really fortunate. The diagnostic laboratories that do all of our blood testing for kidney function, it automatically generates. So it's different when, and because for the, for adults, the equation we use is the CKD epi equation, which uses age and gender, which means that the laboratories can just automatically generate the number from the serum creatinine level. And so that's why it comes on our testing. But this is, as Peter said, this is how we estimate the level of kidney function, and all of our trials and studies are really geared to this, which I think is really important. Because
we need, as I mentioned, height in pediatrics, which no one knows really in the lab.
No. In the interest of time, in terms of management, as one would imagine, lots of questions about diet. I don't know what you say to your patients, Peter, but I tend to say to mine, the patients I care for, that a broad and balanced diet is important. There's no specific diet at this time that I'm recommending, though, for people with specific scenarios or instances, or if as kidney function's declining, I would get a dietitian involved to give specific guidance. For some patients, potassium discussion in more advanced stages of kidney disease or fluid intake and things like that becomes important. Mm-hmm. But maintaining, as you said, healthy weight, a full and broad diet, being physically active, these are really important things at this time. But there's more evidence to come.
And in children, you just want to make sure that they have good energy and protein intake for normal growth.
Yes. And then things like, hopefully this isn't something to talk about in a pediatric context, but in an adult space, alcohol consumption, it's a question I get asked a lot. So I recommend for most patients, adhering to the NHMRC safe alcohol consumption guidelines, which are continuing to evolve, but ensuring there's a number of days of the week which are alcohol-free, ensuring no more than, say, 2 standard alcoholic drinks per day. These national guidelines are continuing to evolve, but providing safe and sound advice that this doesn't represent not being able to drink any alcohol at all for the vast majority of patients, but if one is, doing it in a safe way. And alcohol in and of itself is not necessarily toxic to the kidney, but the dehydration that can come with excess alcohol consumption is. So ensuring hydration, I think, is important. But anti-inflammatories, so NSAIDs for pain relief, ibuprofen. What do you say to people, Peter?
Yeah, as I said before, you can have it, but be wise with it, because, for example, there are some teenagers, girls in our clinics who have very painful periods, and the paracetamol doesn't work. So I said, you can have it, but just make sure that you are well hydrating yourself, that you are not unwell at that time, because we have seen acute kidney injury in kids who have gastro, they are dehydrated, and on top of that, they have been taking, or someone was giving these children non-steroidals like Nurofen. So it is a safe medication, but be wise with it.
Absolutely. And then, probably the last slide we have time for in this seminar this evening, the evidence about long-term tolvaptan use. So I think this is something in the adult space we're beginning to get a grapple on. At this time, the best evidence we have is that the benefits of tolvaptan are preserved with long-term use. And there are some patients who were participants in the very early tolvaptan ADPKD trials who are still on it now, including some in Australia. So there are patients who've been on tolvaptan for polycystic kidney disease for well in excess of 15 or more years now. And I believe there's been some very long-term outcome studies done in Japan, even in latter stages of CKD. So the evidence of its ongoing effectiveness has been preserved. It does what it says on the label in general. As with all treatments, there are things to be aware of. There are some potential side effects that might be experienced, and it may not be the right choice for every patient, but in terms of the benefit, it's been, I think, a really positive thing to see that it does appear to be benefiting patients in the way that the clinical trials told us it was likely to. But yeah, there's been some movement of new clinical trial evidence in the pediatric space, I think, Peter, hasn't there?
Yeah, it's evolving.
Yes.
It will take many years. Yeah.
Yes, absolutely. So now, Carolyn, I think that might be all we have time for, because we've reached.
Can I just very briefly interrupt? Just sorry. Jennifer wrote a Q&A here, and she was saying that her son, who is 39, is finding it really difficult to find a GP who is interested or who knows about polycystic kidney disease. And that, from my perspective, and Andrew can answer as well, I think that comes down to, again, as I said, education of people. And that's where the KidGen is really important, is distributing this knowledge to the community of providers as well, and people with ADPKD as well, and other genetic kidney diseases. But it's unfortunate that her son can't find a provider who is interested.
All right. Well, thank you so much. That was so insightful, and it's always really valuable to hear about the latest emerging evidence-based information and research that's on the cards. So on behalf of the PKD Australia crew, I would just like to extend our absolute appreciation to both Professor Andrew Mallett and Dr. Peter Trnka tonight. And thank you again for sharing your time and substantial expertise in this subject matter. And finally, thank you to everyone who's taken the time to join us tonight also, and to those who took the time to send in questions in advance. The content was incredible, and I really hope that was answered. I know that Andrew and Peter have put in a lot of time into the slides tonight. So if there is anything else that crops up that perhaps you'd like more information on, or that hasn't been covered in as much detail, please feel free to contact PKD Australia, and we will certainly send those questions through to Andrew and Peter. And we hope that was really insightful, and a recorded version of this webinar will be released on our website shortly in the next week or two. So the next webinar in this KidGen series will focus on PKD genetics and your family, and that's due for early 2024. So more information will be released in the upcoming weeks. So please do look out on the PKD Australia website and in our newsletter. So that's it for tonight. So thank you, take care, and thank you again for your support. And we look forward to having more events and seeing more of our supporters next year. Thanks again. Good night.